So, ladies and gentlemen, it is a distinct pleasure for me to provide you some information from Hanover, Germany. My name is Professor Carsten Knobloch, and I'm a trained plastic surgeon. And as the editor of the Plastic Reconstructive Surgery Journal says, we don't own an organ, but we as plastic surgeons, we own innovation. Maybe you know that Joseph Murray was the first reconstructive surgeon to perform successfully a kidney transplantation in 1954, which he received later the Nobel Prize for. And plastic surgery, as you know, is a composite of aesthetic surgery, of reconstructive surgery, of burn surgery, and of hand surgery. And you will see that for a number of these columns, shockwaves have been successfully implemented. Meanwhile, my surgical training took place at Hanover Medical School, which you can see here. And for 11 years, on the left-hand side, these were my surgical trainers. Professor Klempner for general and transplant surgery, Axel Haberich for cardiothoracic and transplant surgery, and Christian Kledek for trauma surgery, and Peter Vogt for plastic hand and reconstructive surgery. And I am therefore a board certified general surgeon, a plastic and aesthetic surgeon, a hand surgeon, a sports medicine specialist, and an emergency medicine specialist. And as of now, I'm the president of the German-speaking International Society for Shockwave Therapy, DIGEST. I'm the chief communication officer of the International Society for Medical Shockwave Therapy, ISMST, and I'm the editorial board in some journals and a fellow of the American Journal College of Surgeons. And when I was in plastic hand surgery, I was the head of the burn ICU. And I can tell you up front that shockwaves are a healing accelerator. This is my private practice, which I started in 2012. You see the shockwave machine, and you see here the entrance. And there are a number of success factors in shockwave therapy to be considered. On the one hand, technology. Second, education. And third, experience. Some words on technology. As you know, shockwaves are acoustic waves which you can hear, and they travel depending on technology used. For example, radial therapy is much more superficial, while focused devices can achieve much deeper penetration depth. And a focused electromagnetic shockwave, like the one from Storz, is then generated electromagnetically, and then it's transferred through tissue, and you see how the shape of the focused shockwave is changing over the penetration depth. And you can fine-tune both your radial and your focus device. And if we talk on focus device, it is essential if we consider superficial treatments like wound treatments for diabetic wounds, for burn injuries, and so on, to be superficial. And therefore, I would recommend to use standoff number 2, which you can see here, for all superficial treatments like skin treatments, burn treatments, wound treatments. So please use standoff number 2 for using focused shockwaves. And if we talk on radial shockwaves, there are a number of different applicators meanwhile available, where you can somehow influence the pain and the energy transmission. And there are, for example, there is a soft tissue applicator called F15 wide soft lens, or even the Atlas applicator, which will somehow facilitate radial treatments even in very, very painful situations. So you can fine-tune your machines with different applicators. And some words on energy. 40 years ago, for kidney stone resolution, very, very high energy levels were used to elicit a mechanical response, speaking kidney stone resolution. And over the decades, the 4 past decades, the energy levels went down and down and down, and we are now aware that we are more in a regenerative approach when using radial and focused shockwave therapy. So we are using much lower energy levels. And by definition, low energy is in between 0.05 to 0.1 millijoule. Medium energy is in between 0.1 and 0.25 millijoule, and high energy is by definition higher than 0.25 millijoule per square millimeter energy flux density. And if you use radial shockwaves, for example, you are only able to cover the low and the medium part. And as you see, one bar with all calculations and assumptions is somewhat 0.05 millijoule, 2 bars 0.1 millijoule, 3 bars 0.17 millijoule. So you are mainly in the low to medium energetic with radial shockwaves only. So low and medium is covered by radial and focus techniques, and high energy is only covered by focus energy in the moment. And last year, when I was in Bangkok, I promoted a new concept with very low energy named nano energy. It's in between 0.01 to 0.05 millijoule or 0.3 to 1.0 bar. And there are a number of indications and tissues which react to different energy levels. So nerves, for example, peripheral nerves, only need very low energy, so nano energy is enough for treating nerves. Skin the same, so nano or low energetic is sufficient to elicit some beneficial effects. Even same thing for the lymphatics. If you treat muscles, you have low to medium energy, tendons, medium energy, brain, high energy, and even bone, even higher energies. And in my view, at the moment, I'm using nano-energetic for nerves, for skin, and for children and adolescents, just to give you a background on these physical issues. And the second parameter beside energy or pressure is frequency. And it's very important, in my view, to document and to keep an eye on your frequencies. With focused shockwaves, you are in between 1 to 7 hertz. With radial, you are in between 5 to 21 hertz, and with the new V-Actor vibration tool, with the current one up to 35 hertz, and with the V-Actor high F, high frequency, up to 50 hertz. And in my view, it's quite wise to combine radial and focused shockwave in one session. So focused shockwave locally focused on the point of pain, on the ulcer, on the feeding vessel, and radial as a regional therapy around the treatment area for lymphatic drainage, for example. So it's very wise, in my view, to combine them both. So if we talk shortly on evidence and type in PubMed ESWT, you see 2 scientific waves, and on the y-axis you see the number of publications per year, and you see that more than 150, 200 papers per year were written in the early 90s, and the same holds true in the last decade. So we see at the moment more than 250 publications every single year dealing with ESWT. And depending on techniques used, for example, for focus techniques, you have electromagnetic generation by Storz, for example. You see the highest number of publications for electromagnetic in contrast to electrohydraulic or piezoelectric devices. And the same holds true if you compare focused in green and radial in yellow. So the numbers of publication, and we have a substantial amount of publications for focused electromagnetic shockwave therapy. And if you, by chance, are in China and go to a library, the very first book I ever found on shockwave therapy was published in China in '91, as you can see here. In '97, Werner Siebert from Germany published this book. It's one of the earliest books in English. 2000, Coombs and Wolfi Schaden. In 2007, Ludger Gödesmeyer and Dr. Weil. Professor Wang from Taiwan and Wolfi Schaden published in 2017 Shockwave Medicine, and recently in Germany this book was published by Corey Ulrich. And there are even English-speaking publications in the level 10 publisher covering different aspects of shockwaves, so tendon problems, myofascial problems, shockwaves in sports medicine, shockwaves for facial treatments, and you can see them highlighted here. And I wrote myself 2 books by now in 2018, Shockwaves in Aesthetic Medicine, Burns and Dermatology, and you will see some of it in the later talk. And last year I did a book on shockwaves in hand surgery only. So we have a significant amount of data, evidence-based data published and collected in these type of books. If we talk on timing, usually we do therapeutic shockwaves after anything has happened. So for improved function, if a tendon is painful, if you have an ulcer, you want to have some healing, you will have to have some less pain in tendon problems. However, there's something to the concept of preventive shockwaves before something happens, before an operation, to maybe have less scarring, faster healing, or a preconditioning, for example, before flap surgery. So there is something in at least in my view, that there are circumstances where preventive shockwave therapy is quite attractive. There is one study published from Austria in this year, before and after abdominoplasty, and they did a split abdomen approach, and you can see on the one hand a single focused shockwave treatment on the day before surgery, and on the other side of the image the placebo sign, and they could show at 6 weeks and at 3 months a significant improved scarring in the area where they did one preventive shockwave therapy 1 day before scheduled surgery. And in my aesthetic book, there is a nice chapter from Peter Morgard showing the kinetics of normal wound healing, as you can see here, an inflammation phase, a cell proliferation phase, and the matrix remodeling phase. And then when excessive scarring is taking place, an upregulation of certain cytokines like TGF-beta1, TGF-beta2, EGF1, and so on, depending on the kinetics. And there are, depending on the cell process you are in, different effects of shockwave therapy, which can help a more regular, a more normal tissue healing. And in the book, which I highlighted beforehand, Peter Morgard did some recommendations on the numbers and on the details of parameters for focused shockwave for wound healing, for example. If you use a Storz device, he recommends in between 0.03 to 0.012 millijoule, 500 to 1000 shots, but you will see it really depends on the size of the wound. Once a week, and usually 3 treatments. If you do scar treatment, for example, he had slightly higher energy levels, slightly higher numbers of shots, and slightly or significantly higher number of treatments, so 8 to 12 treatments, to facilitate less scarring. There is data from Germany in 2010 published that in the skin grafting donor sites, one focused shockwave can improve healing by 3 days. And this was a randomized controlled level 1A trial. And the same working group, Bernd Hartmann, who is the chief of the largest burn ICU in Germany, and a friend of mine, he published in the Annals of Surgery in 2010 this landmark study showing that in superficial 2A degree burn injuries using focused shockwave will accelerate healing quite significantly. As you can see here, the numbers of totally epithelialization is in the shockwave group significantly higher and faster by 3-4 days in contrast to normal healing. So you have a healing acceleration. And more on this in my book. If we shortly touch in reconstructive surgery, as you know, soft tissue effects need reconstructive surgery. And there is a concept by Matthias and Nahai published in 1982 of the reconstructive ladder. So if you have a defect, you try to solve the problem with the easiest way to do. So if possible, do direct closure. If it's not possible, then consider skin grafting. If not possible, consider local flap surgery. If not possible, consider free flap surgery. That's the concept of reconstructive ladder. So in this case, for example, which I operated on myxofibrosarcoma, resection and primary closure possible. In this case, skin grafting after debridement for Fournier gangrena. In this case, Kaposi sarcoma, I did alloskin, and interestingly, with Shockwave, it healed in with the help of shockwaves as an anti-immunosuppressant in this case. In this case, I did a twin flap for closure of this basal cell carcinoma. Or here, free flap surgery, latissimus dorsi flap with the vessel preparation, as you can see here, me on the microscope doing the micro anastomosis and latissimus dorsi flap. And 10 years ago, I already had the idea with my chief, Professor Vogt, that shock waves, as you can see here, might perfectly fit in an idea or concept of a reconstructive clockwork. So not considering stepwise like the reconstructive ladder, but even as an integral part, shock waves in combination with, for example, fat transplantation, with ADMs, with expanders, with skin or with perforator flaps. So the new concept is that shock waves will help your surgical techniques or your different techniques to have higher success rates. And that's how I started in 2006 with my dual-lid machine, as you can see here red. And I started because I was working in plastic surgery, for example, preconditioning my own flaps. So this was a anterior lateral thigh flap, as you can see here, with a perforator. And I preconditioned before surgery the flap to achieve higher success rates. Or here in a patient with an MLD flap, which I did on his barefoot, on his rear foot, and he had some additional metatarsal fractures. So I did focus shockwave for the metatarsal fractures. In the aesthetic book, we have a nice chapter from Scandinavia showing that in wounds, you not should only treat the ulcer, as you might see here, the ulcer, but also the feeding vessel and the feeding nerves for that given ulcer. So depending on location and depending on size, you should adjust your parameters and you should consider the anatomical ways. And they recommend to do, for example, shock waves, not only here on the ulcer, but also on the feeding vessels like here, on the feeding vessels like here, on the feeding vessels like here. So consider anatomy in combination with your shockwave machine. In the ISMST, where I'm the communication officer, we have a course on wound healing, and our general recommendations overall machines are in the moment to use in between 1.1 or 0.2 millijoule, 2 to 5 hertz, 3 to 6 sessions, and depending on wound size, you should adjust your numbers of shots. So, for example, if you have a 1 by 1 centimeter wound, you will end up with some 360 shots. If you have a 2 by 2 wound, you have 350 plus 40, meaning 390 shots. The only issue is that you get an idea that depending on your wound size, the larger the wound, the more shots you will have, because you have to transfer somehow the energy. And you can even combine it with different techniques which are commonplace. For example, in superficial 2A burn injuries, as you can see here, we used a BioBrain glove. And then you can, in addition, use your shock waves to accelerate healing even in these 2A burn injuries, for example, in combination with the BioBrain glove. Or with the Integra, you can use a acellular dermis substitute like Integra and enhance healing in that cases. And this was a gentleman after a significant burn injury and a myocardial infarction because he fell down. In lymphatics, and I mentioned it before, in secondary lymphedema, shockwaves play a huge role where you can facilitate lymphatic outflow. And there is even a pilot study from South Korea, from Seoul, showing that the volume of the affected arms is reduced significantly by focused shockwave in that case. Some words on the mechanisms. As you are in plastic and reconstructive surgery, you are aware of vacuum therapy. You might be aware with expander therapy. You might be aware of bone healing, bone transportation therapy. So these are all, in a way, mechanotherapies. And you can see shockwaves in that same way because the acoustic waves is translated with a process called mechanotransduction in a protein response. So the term is mechanotransduction. And we have data showing that, for example, focused shockwave can activate stem cells, published in Cardiovascular Research in 2016. We have data from South Korea showing that in hypertrophic scar, TGF-beta and different cytokines are modulated by shockwave therapy. And this is especially interesting if you are thinking on scarring, if you're thinking on Dupuytren's disease, if you're thinking on Lederhose disease, because shockwave can be antifibrotic by modulation of TGF-beta. And in terms of burn injuries, there's an, in my view, landmark study from Seoul again, showing that using shockwaves after the burn scar has established, you can significantly affect burn pruritus, so itchiness of the skin, significantly. As you can see here, they did a randomized control trial, 3 sessions, and could reduce the itchiness significantly in the intervention group, while no such effect in the control group. So we have different effects. We have data showing that the reduction of pathological nerves is achieved. We see a release of substance P. We see an increase of microcirculation, both for blood and for lymph vessels. We see an increase in cell wall permeability. We see a release of nitric oxide. We see a stimulation of growth factors like VEGF, TGF-beta, TGF-beta-3. We see anti-fibrotic effects. We see antibacterial effects. We see stimulation of stem cells. And we see a stimulation of immune system. So you see, it is not only a single mechanism involved in shockwave therapy, but it's a plethora, it's a concert of different effects, and in the end, it's a healing accelerator. And with a short outlook. This is my friend Paul Tehran from South America. And this is a lady, 22 years after a severe biking crash, and there was a lorry driving over her pelvis. And as you can see, a large amount of scarring. And he did only radial shockwave therapy, 6 sessions, 3 bars, 7 hertz. And 3 months later, you see how the scars look. So before and after. Again, before and after. You can think about a combination of shockwave with cell-assisted lipotransfer, for example. This is a case, chronic wound after irradiation. So we did the combination of direct suture and shockwave and could show an increase in tissue saturation by 35%. And you can even combine it with fat stem cell transplantation. And as you know, adipose-derived mesenchymal stem cells can do various things. And there is data from Austria showing that if you do shockwave treatment just before liposuction for your adipose-derived stem cells, if you are doing it 1 hour before, you can increase and process your ASCs, you can increase the viability and the quality of your fat grafts quite significantly. And we just wrote, or I wrote something on this issue in German last year. So stem cells and shockwaves in aesthetics. Some more words, just as an outlook. You know this gentleman, Marcus, as in aesthetics. And we have several data showing in cellulite. We are starting in the phase for scarring and in combination. And as you see here, we did a randomized trials on cellulite and could show after 6 treatments a significant increase or improvement in the cellulite severity scale. We could show a significant detonization of frown lines with focused shockwaves, as you see. More on this in the book. And in the book, we have substantially more parameters for every location, for every indication in terms of focused and radial shockwaves. And so coming to the end and thinking on the 4 columns, in aesthetic surgery, you can use shockwave for quite a number of indications. In reconstructive surgery, you can use shockwave for a number of indications, preconditioning, improvement of flaps, and so on. Burn. And in burns, you see an acceleration of healing. And in hand surgery, this is a different topic. You can help people in hand surgery with shockwave. Thank you very much.